I think it's useful before we conclude to also look at how the scientific and the clinical community recognizing the massive unmet need that we're not doing anything to the disease modification for these myelofibrosis PV-ET patients. There's a lot of interest in testing the newer molecule, whether they're focusing on JAK1, JAK2, or other targets as well, because the underlying molecular characteristics are very, very complex. There's so many pathways involved. So one of the things which is important to assess that is the role of combination therapy. Okay? So if you use the backbone of one of the approved JAK2 inhibitor, and now we have 4, of course, beyond Ruxolitinib. For a long time, for over a decade, we only had Ruxolitinib, but now we have Fedratinib, Tukratinib, and Momelotinib as well. So what is the impact of the JAK2 inhibitors as combination therapies in myelofibrosis? And many people have been doing work on this, but there's one particular guy who's spending a lot of time on this, and that's John Mascarenhas at the Mount Sinai Hospital. And he was there, he chaired the session, and he shared some of his thoughts as well. And so it's interesting how you can combine these different agents. And of course, most of the studies are single arm, phase 1, phase 2. But there's also recent randomized prospective phase 3 study, and he presented some of the updated findings on that. And that is looking very interesting. Is the combination of Pelabresib and Ruxolitinib is the study is called the Manifest-2. It's been going on for a little while, and that's a randomized phase 3. And then there's a very exciting randomized phase 2 study and combining navitoclax with Ruxolitinib. So these are early days, and you having molecular responses. So patients with the JAK2 V617F have shown reductions in their mutation burden and so on. So I think it will be reasonable to say that today, as many people now will be celebrating the Halloween, and we have 2 more months left to conclude this year. There are 6 FDA-approved therapies for patients with chronic myeloid leukemia, and there are 4 FDA-approved therapies for patients with myelofibrosis. This is a remarkable achievement over a relatively short period of time. So that is a positive thing. The negative thing is also that when you have an influx of so many drugs approved, and many of them are approved for first-line therapy, it's a massive nightmare for the everyday clinician sitting there with the patient opposite him or her, trying to make a decision as to what is the best possible treatment algorithm to adopt for this individual. And this is where personalized medicine comes in. So another good friend of mine, Jyoti Nangalia from Cambridge, was also there at the Congress, and she in fact gave a beautiful presentation to open the meeting on the Thursday morning. She spent a fair amount of time looking at the genomic characteristics and how people can utilize this information to personalize therapies for individuals. Okay? So we don't have time to go through this now, but the long and the short is that there's a lot of clinical excitement as well now. That fine, okay, we've done well, we've got these therapies, but we've got massive unmet need. Now, if we put our tools together and look at the treatment armamentarium available, look at all the genomic characteristics which are coming out in a validated way. You see, as I spoke last time, a few years ago, whenever you have a genetic test, there are 2 major important components. You do the analytical validation, and then you move it to the clinical, and then it's the clinical validation which is going to determine how that particular test is going to be utilized. So I think this is where the MPN field is going, and so we have a lot of excitement. And you will be very welcome to come to listen to some of our presentation during the ASH meeting and the post-ASH workshop. So thank you very much.